Right, cold emergencies. So you can split cold injuries and emergencies into localized cold injuries and systemic cold injuries. We're going to cover them separately. So local cold injuries, there's trench foot. So this is from World War I, where I got that name from the trenches, which is where the feet are constantly cold and wet. There's chilblains, which is when the feet are left cold and wet, they get very inflamed. Frostnip, which is really not its own disease process, it's just the early stages of frostbite. And then frostbite, which is ice crystals and freezing within the body tissues. Obviously, Australia is pretty hot. We don't see too much of this here. So most of the findings and data are from the Nordic countries around the Arctic Circle. So localized cold injuries are exclusively caused by environmental exposure as opposed to systemic cold injuries, which can be caused by other things, and we'll go into that. So pathophysiology, there's two ways that you can get a localized cold injury. So trench foot and chilblains are non-freezing injuries. If you remember from the altitude lecture, prolonged vasoconstriction starts to cause capillary leak, which causes inflammatory responses and eventually capillary breakdown. Then you have freezing injuries, which is fairly self-explanatory. When you freeze a bottle of water or something, you need to leave that space at the top. If you don't, the ice expands and will destroy the bottle. Anyone who's ever left a beer in the freezer is aware of that. And the same thing happens in your body. So if ice crystals start to form within the cells, they will expand to a point, but as that water freezes and expands, the cell will rupture. And that causes obviously direct tissue damage. It also causes cellular dehydration due to water being drawn out of the still living cells towards the ice. So I've just included some pictures here. So chilblains is very itchy. I've heard it described as kind of maddeningly itchy. There'll be reddening and swelling, and it's an early stage of a localized cold injury, so less than 24 hours. If whatever that irritant, that wet, cold, environment is not resolved within that time period, it can progress on to trench foot, so the middle one here, and you can see that those feet are starting to look profoundly unhealthy. The feet in trench foot will be cold and pale. Patient may not be able to feel them properly. They may be very numb, and may or may not be pulseless. And then frostbite, you're not going to miss. That's where the extremity is pale, cold, stiff. If it's really frozen, rock solid, if you push it, it will just feel like a hard block of ice, and you won't be able to depress the skin at all. That's non-salvageable by the time it's got that rock hard, but frostbitten extremities can be salvaged in some circumstances with good treatment. So there's no real mystery as to the treatment. You need to rewarm the frozen part or the cold injured part. So what you want to do ideally is immerse, if I've got a frostbitten or have some sort of localized injury to my hand or foot, you want to immerse that in warm water. But that's not, we don't carry warm water around in the ambulance. So what we need to do is just be a bit smarter about it. So first thing first, stop the cold. So we need to get the people away from the cold, damp conditions and remove any wet clothing, wet shoes, socks or anything over the affected hand or foot. And then we're just going to have to do our best. So we have self-warming blankets now. You can wrap up the foot, leg, hand, ears even in that self-warming blanket. Obviously, I've put a picture of the air conditioning dial here. Crank that right up. You as the paramedic will want to be sweating and uncomfortable so that patient can be getting warmer more quickly. It's very important if you're going to dry, if you have like a wet cold injury, don't rub it because the skin will just slough off. you want to make sure that you pat dry with a towel or paper. In frostbite, again, this isn't really going to be a problem in Australia, but if you were a paramedic on the ski fields or something, potentially you might see this. The worst thing you can do for frostbite is thaw the affected part and then have it refreeze, because then you get all the damage from the first batch of ice crystals forming, which then thaw and melt, and then new ice crystals form, but they don't form in the same spot. So you're going to have healthy tissue that was salvageable now get destroyed in the second freezing. So don't attempt to thaw out a frostbitten foot or toes, for example, until you're sure that they're not going to be able to refreeze. Just like with burns too, you want to get out rings, bracelets, watches, because these injured areas are going to become so inflamed, they're going to swell dramatically. All right, onto systemic cold injury. So hypothermia, any temperature under 35 degrees. And as I said before, localized cold injury is always environmental, but with systemic cold injuries, there are other causes. So we still have environmental, and that's probably, to be honest, the most common. That's that classic hypothermia. But you'd remember from when we've done, the triad of death in multi-system trauma. In trauma, people start to get cool, and we need to correct that hypothermia as well. Burns, your skin loses its ability to vasoconstrict and thermoregulate, and will just passively lose heat. Some drugs can cause a decreased heat production as well, things like beta blockers, and any sort of brain damage that affects the hypothalamus, which is what determines your core body temperature. For example, strokes can also cause hypothermia as well. If someone's hypoglycemic, they're not going to be able to create cellular energy, so they're not going to be able to create heat as a byproduct of metabolism, and they're going to get quite cold as well. And then obviously sepsis, that distributive shock, patients are just going to lose heat passively as well. So we've got different presentations of hypothermia. Mild hypothermia is when, so between 35 and 32 degrees, body's functioning normally, patient will feel very cold and will be actively shivering. Piloerection is your hair standing right up on your arms and legs. And they'll be engaging in some sort of active behaviors to try and get themselves warmer. Moderate hypothermia is when you start to get problems. That's when impairment starts to set in. So shivering stops, sugar production stops, or slows, I should say. Breathing slows, patient starts to get confused, and of course once they hit this point, they're less able to engage in those behaviors that are actually going to help them get better. Is when you might see some arrhythmias as well, such as atrial fibrillation, or more commonly sinus bradycardia. In severe hypothermia, so under 30 degrees, patient will be probably pretty profoundly unconscious, may appear to be deceased, so you may not be able to feel pulses, may not be able to feel them breathing, and this is where the ECG will potentially show VF. Under 28 degrees is likely fatal. So there's a thing called an Osborne wave, which is quite specific to severe hypothermia, and it's this little notch, a little bit like the one you see for benign early repolarization, but without the ST segment raised. So if you see this on a ECG in a hypothermic patient, it's worth noting because it means that the cold has reached the point where the heart is now being affected. And if they can start to have this sort of change, you have to start worrying they might have some other arrhythmias too. Sinus bradycardia, atrial fibrillation, and if you don't do something about it in a worst case scenario, if their temperature keeps dropping, potentially ventricular fibrillation. So the treatment largely centers around the severity of the hypothermia. The great thing about hypothermia is that you've heard of therapeutic hypothermia. As your body cools, it's protective of your brain. So unlike many other conditions, you don't need to be really aggressive with the treatment of hypothermia as long as the temperature is over 30 degrees, which is still very cold if someone's 31 degrees. As long as they're over 30 degrees, people will generally be able to rewarm themselves, given enough time. And because of that neuroprotective effect of cold, they won't have any brain damage from it. So if they are over 30 degrees, passive or active rewarming with a blanket is sufficient. Now we would use a self-warming blanket because we carry those, and that expected temperature increase of 1 Celsius per hour doesn't sound like that much, but that's actually probably not, we're not going to be able to accomplish that pre-hospitally. That would be something they would be able to achieve in a hospital with multiple interventions. So all we're going to do, heat the environment, keep the patient dry, and put a self-warming blanket on them. Now, if they are under 30 degrees, passive rewarming is not going to cut it. They're going to have to be actively rewarmed. Under that temperature, they won't be able to warm themselves. They'll just continue to get colder and colder. So we want to apply an external heat source. As I've said, we have self-warming blankets. In hospital, they have these things called bear huggers, which are these air mattresses or like air blankets covered in little perforations that blow hot air all over the patient, so it keeps them dry and warms them up over their entire body. In hospital, they can give warm fluids, they can intubate and ventilate the patient with warm air, so sort of warm them up from the inside out, and in serious cases, they can put them on cardiopulmonary bypass and the machine can warm the blood and then return it back to them. You need to be careful in both moving the patient and in warming them too quickly, because you can theoretically precipitate VF. I'm not sure how strong the evidence is on that, but there are some case studies for it. The idea there is that if you warm them too quickly, the arms and legs are going to warm up faster, and all that blood will return back to the central circulation while the heart is still very cold and stunned, and it actually won't be able to deal with that return of blood and potentially go into VF. Now, if they do go to VF, you want to rewarm them as rapidly as possible. Pre-hospitally, you do what you can do. But it does change our treatment in a few ways. So we don't give any drugs until the temperature's over 30 degrees, because if you give adrenaline into the arm, it's just going to sit there. Even if it does get to the heart's not going to be in any state to react to the adrenaline at that temperature. When they're over 30 degrees but under 35 degrees, you can start giving adrenaline, but you want to give it at double the regular interval. And if you do defibrillate, if you're in Queensland using the core pulse, you're just going to use 200 joules anyway. But if you're in other states that have a like a life pack that lets you escalate the joules, you just go straight to 360 and defibrillate at your maximum joules straight away. Now, because hypothermia is neuroprotective, there's a saying that they're not dead until they're warm and dead. So you're going to transport all of these patients and let them continue the resuscitation and call it a hospital, in all but the most extreme circumstances where the transport time will just be hours and hours if you were somewhere extremely remote.